It's a great opportunity, and thanks, Danielle, for putting it on. So ISTH is just happening there. I'm sure people have told you. So the experts are here in Melbourne.
And that's the reason why we've done today.
So it's a really good opportunity to tag along. And I thought I would do a 5 to 10 minute presentation, literally, and then open up for discussion, because you guys all know about ITP very well. So some of the stuff that I'll be mentioning is clear cut, but these are the sort of cases that, you know, these are real cases. No one here, I don't think, but you know, the urgency with which patients come to see me with bruising is genuine, because the usual scenario in this setting, and I don't know if you can relate to it, is that the parents think that the child has got leukemia. That is by far the most common clinical scenario of a patient presenting with bruising. And the important aspect from a haematologist point of view, from a diagnostic point of view, whilst occasionally there's some uncertainty, as long as the rest of the full blood count is normal, it's a relatively clear-cut diagnosis from our perspective. We don't have to do too many more tests. When I first started in haematology decades ago, we used to do lots of bone marrow examinations on these kids because we were unclear, whereas studies have shown that if everything else is normal and it's only the platelet count which is markedly reduced, which is very low, we don't have to do bone marrow examinations, so we've stopped doing that, at least at diagnosis. And the examination is important because I'm sure you're aware that part of the blood forming system is the spleen and the liver, and we have to check to make sure that they're normal as well. At the Children's Hospital, we tend to get referred many cases that are a bit more complicated rather than your standard, if there is such a thing, acute immune thrombocytopenia, because many of those acute ITPs are managed by general paediatricians or indeed GPs. But we get patients who have had lots of previous treatment, and we'll talk about treatment in a minute, but treatment is associated with side effects, as you will be aware. Nothing is risk-free. So we tend to see patients that have had significant treatment and unfortunately significant side effects as well. We see young kids, you know, little kids and toddlers running around who are less than 12 months of age, who are unsteady on their feet, clearly represent another degree of anxiety for parents, because they'll topple over, and we know that the risk of head injury can lead, or head injuries can lead to intracranial bleeds. You know, this walking, any child that's walking around the starting is prone at least to getting an injury. So this is there's lots we don't know about ITP. There's an enormous amount, but we do know a couple of things. So this is a graph of a study back in 1953, so 60 years or so ago. What they did, they got a whole lot of medical students lined up, and they took some plasma out of a patient who had ITP, and they injected a bit of plasma into each of those medical students. They had to. It's not going to get past ethics. Yeah. So sorry to replicate, but we now know that there's something in the plasma that causes ITP, because you see the platelet count in these patients, these medical students, it quickly drifted down, some quite low, but then when the plasma was out of the system after a few days, it responded. So we know that it's something in the plasma that is causing ITP. And the way that we've described it in the clinic is we think it's an antibody against platelets. So that's what we know about it. And to any huge extent, that's probably really some of the limits of our medical knowledge around ITP. Why it happens in some kids and not others, we don't know. Why it goes on for longer in some kids than others, we don't know. Why some patients bleed more than others despite the same platelet count, again, we don't know. So I think the ability for people to get together and discuss these questions, I think, is really helpful. So thanks again, Dan, that's really helpful. But ITP in children, as I've said, is a diagnosis of exclusion. Serious bleeding can occur. So up until this year, and I'm not giving anything away, up until this year we hadn't had a death from ITP for over a decade at the Children's Hospital, and the Children's Hospital tends to collect the more chronic cases. Unfortunately, there was a child this year who passed away primarily a result of ITP, an older child. So it can occur, but most of the time it doesn't. Most of the time ITP in kids, we put a circle around 80%, get better without any need for treatment. And the problem is that we can't always identify who's going to get better quickly and who's not. Although there is a bit of information. If you're a male and you're young, as in early childhood, you've probably got a better prognosis compared to a female in an adolescent period. They're the ends of the spectrum. We do know that those risk factors are associated with prolonged ITP. But most get better. And I don't see most ITP. Most ITP, as I see, is seen in the general paediatricians. And when I talk to the general paediatricians, because we could easily advocate for centralising care, and I'll talk about that in a minute, but centralising care means that you get a bit more of an understanding around the biology of ITP. It lends itself to setting up registries to fully understand these elements and when treatment's required and when treatment's not, and prevent some of the morbidity and mortality around ITP. But the paediatricians like treating ITP because it gets better. It gets better. So if you look after a disorder that's got an 80% rate of getting better without doing anything, it's actually so we try and drag things out of general practice. Hang on, we'll look after that. And there's many more paediatricians than there are haematologists, so it can be a bit of a battle to look at the centralisation of care. But as a tertiary institution, or not just in Melbourne but the other centres around Australia, the haematologists are keen to look after ITP. This is the biggest, so this is an intracerebral hemorrhage. I'm not sure how much Rob or the other speakers talked about bleeding in the brain, but that will cause mortality. That results in the death of children, unfortunately. But it's really uncommon. It does happen, and as I said, unfortunately we've had a case at the Children's this year. But it's really uncommon. We understand that if you've got more mucosal bleeding, you're more at risk. If you've had recent injury to the brain, you're more at risk. But this can be really difficult to diagnose, unfortunately, and predict. As a result of the recent events at the kids, we're now saying to patients, and you might have heard this, we used to say, we want to know if you've been involved in any trauma, or if you've got mucosal bleeding, we want to know about you straight away. The third thing is we're saying if you have a headache that's not relieved, if the child has a headache not relieved by a simple analgesia, we want to know about it. And not to go into too many details about that previous case, but that patient had a headache for at least 24 hours, not relieved by simple analgesia. And that might have been look, we look in retrospect, I'm very clever in retrospect, but had we been able to get involved in the case earlier, that might not have led to the outcome that it resulted in. But this is with the retrospectoscope. This is with hindsight, and so that's why we as paediatric haematologists in Melbourne, and will probably recommend it nationally at least, they're the three guidelines that we want to know about, three things that we urgently want to know about. And that information can be disseminated through ITP Australia. They're simple. And sometimes we're going to overdo it, but I don't think we will undo it in that space. So that's mortality, unfortunately, with ITP. Lots of patients, only 3 ICH. There was another earlier study of a registry, the Intercontinental ITP registry. They had 2,000 patients and none of them had intracranial hemorrhage. So this was a very small study. That's why the estimate is quite high. That's nearly 1%. That's 1 in 100. I'll see at least 100 kids a year, at least. That uncommon, but it does happen with obviously devastating consequences. What's the other morbidity? Bruising, unsightly. You go to the supermarket, people come up to you and say, "Why are you beating up your kids?" That happens. You come into the emergency department, you get asked by the emergency staff, have you hit your child, that sort of thing. You know, that does happen. And we've had cases where Department of Human Services have been involved. Fortunately, you know, inappropriately, completely inappropriately. Epistaxis, nosebleeds can cause, you know, that's awful for kids at school. You know, remember going to school and seeing a nosebleed, everyone goes, "Ugh," you know, that can cause a bit of social disharmony and isolation. Menorrhagia, girls, so I look after kids with bleeding disorders, and so I fortunate enough to look after lots of girls who have heavy periods. Girls are designed to have probably around 50 periods in their life, and at the moment, because of early menarche, late menopause, not many, they're having about 400. So girls don't have to bleed as often as they do. The only logical reason for having a period is getting pregnant. So talking and working closely with the gynecologists, we think we can control this better. But it has to be almost medicalised instead of, you know, talking to me about periods. Girls, you know, feel awful, the poor things, but we just medicalise it. We just make it a, you know, this is awful for you. So we do our best to deal with some of that awful self-consciousness of these 12, 9-year-old girls who get periods. You know, they generally don't have the experience to deal with it. But I spend a bit of time with this, both parental and patient anxiety, because there's no problems. We're paediatric doctors, and when it's your own child, you get very anxious. When it's someone else's child, it doesn't really matter. So just make it for absolute clarity. This is not in any pejorative or judgment element. I deal with anxiety because it's a real thing, because patients and their parents are dealing with a potential life-threatening bleeding disorder, and here I am saying, you know, you'll be right, off you go. So I get it. This is in no way is this being, you know, this is where at least personally, I spend a fair bit of my time, because there is a real risk of morbidity associated with ITP. Putting your child in cotton wool, for lack of a better term, and I can go through a number of different scenarios where the parents have been anxious, entirely appropriately, don't get me wrong, I'm saying entirely appropriately, but they've contacted the school and they've taken to wrap foam around all poles around the school. That's going to impact on a kid, isn't it? Why is that? Oh, because of her, you know, and you know, I can give you lots of examples. Kids not being able to play any sport at all. You know, there's risks and benefits with everything you do and don't do, but no sport at all. So why can't you play? Because I've got ITP. The psychological disharmony that can cause in particularly boys, but girls completely as well, can be really awful. So the problem is even though I'll say, yeah, you'll be fine, this will get better, it doesn't always get better. Patients do bleed, and I can't predict who will. So that's why this is a really vexed issue. It's tough. It's really very tough to be absolutely clear. Generally, going back to the fact that intracranial hemorrhage is really uncommon, we just have to be clear that we're not doing too much harm by restricting people, because there's risks and benefits with everything we do and don't do. IT treatment, this is my perspective. First line, observation is treatment. Observation, doing nothing is a form of therapy. There's no doubt about it. So I know this is slightly different. People will say these are your first line treatments. But first line is treatment, and that's dealing with some of the other morbidities around haemophilia that have been discussed maybe today. Second line, steroids and IVIG. Third line, MabThera, splenectomy and thrombopoietin agonists. And fourth line, you've got other immunosuppressants. That's sort of a framework that, whilst you look in the literature, people have got slightly different perspectives and say steroids might be slightly slower, IVIG might be slightly faster. There isn't any absolute guidelines. The guidelines that are out there are what we call level C evidence. We try and grade evidence. Level A is the best one, where you've got 2 patient groups and you treat them differently and compare. Level C is basically people sitting around and saying, yeah, that sounds like a good idea. we call it GobSat, which is good old boys sitting around talking. That's got, most of this is GobSat evidence. It's not very high level, unfortunately.
And in saying that too, even in adult ITP, what works for one person is not necessarily going to work for the other either. So every journey and every journey is different, and what works for the next person may be very different to what works for you.
The guidelines, for what they're worth, do, at least in paediatrics, recommend that unless there's significant bleeding, which I don't think is too controversial. Then you get into controversy and it just increasingly becomes less robust as you go down that list in terms of level of evidence. So, what needs to be done? I think, again, highlighting ITP support organisations is really very important, because we haven't had a focus to send people to. So I think, ITP Australia is a great initiative, and certainly we would be supportive of getting patients involved. But the whole...
So is that something that maybe, Danielle, you would be putting into practice, or you
So the next,
somebody else?
yeah, so the next phase of ITP Australia is obviously talking to haematologists and talking to GPs, building the awareness for the website to push people to as their first port of call to gather all of this information.
So in paediatrics, so?
Yeah, definitely.
Yeah, definitely.
We are open to every door. Obviously talking to Spleen Australia as well, and we're happy to have all of this information out there. Our mission is to help people really get the information out there about ITP.
Are you also looking at setting up a registry for?
That was one of the things that I wrote down on my list for today, so yes.
So
I think that
registries are really very important, because it increases everyone's awareness of ITP, it becomes a central knowledge. They're not easy.
No.
And
not cheap. They're
no.
not cheap either, yeah.
But there are different models.
Yeah.
It's good though, there's some good grants, or at least Victorian grants, if you've got kind of grants up for.
I'm looking at a number of grants at the moment, both federally, state-based, and through a number of pharmaceutical companies as well. So looking at all of the, if I can get the funding to do X and Y, it's just that we're currently in research and development phase for a few things at the moment. So I said this morning, it's literally just myself doing all the work. So what I can do amongst everything else, and the last 6 months personally for myself has been interesting. So so just trying to get it all done. Yeah. So if anyone wants to help, put your hand up.
There are different models. So there's if you go through an institution like the Children's or Royal Brisbane, there are appropriate checks and balances because you've got privacy, etc. But there are also other models where you don't necessarily have to tie yourself to an academic institution. There are really great benefits, but in terms of the challenges, there are bigger hurdles to be tied to an institution. So just because of the privacy, so the Children's Hospital, for instance, will look at any data that I'm providing has to go through various hoops and hurdles to make sure that we're not revealing personal information. So, but it does happen, it does. There are registries out there, and it doesn't have to be this big. It can be just some basic demographics to start with to make it very straightforward, with the goal of putting modules onto it. So,
and that's one of the things. One of the things I touched on this morning is the member portal on the website is one of the things that we're looking at with regards to being able to go in, register your details, having the information public or private, so you can either share your journey or you can just have it all in one place. And that's one of the things that we're currently looking at the moment as well.
On the different levels of thing, Frankie has been through everything. Now we do IVIG once a month, so forth. We've extended it through. But with obviously, there's been a recent change, obviously, with blood bank around IVIG, which is now meant that obviously there's a certain number that he has to be below, which I guess is more our anxiety necessarily than his, in the sense of going, well, we never want to get there, but now...
You have to get there to get the IVIG, unfortunately.
Is that based on looking at the cost versus reward, saying that, okay, it's costing us too much to do it this way, yet if the child gets
It's based on dollars. The IVIG growth is about 11% per year, each year. So it was just basically doing this because IVIG is clearly not just used for ITP, and it's used for adults, and it's a finite resource, and it's it's irrelevant to you guys, but it's expensive for the government to pay. So they have put increasingly strict criteria on accessing it.
So are they then saying, so if your platelets are not below 30, we don't really want you to happen. You should be able to look after yourself.
Unless you're
But a
actively bleeding.
5-year-old is not the same story, you know. A small child.
Yeah,
is not-
no, I think what you're highlighting, and I totally agree, that's individualisation of care. What they've had to draw a line in the sand on the basis that those studies, particularly around ICH, have demonstrated that ICH doesn't happen with a platelet count above 30 unless there is significant trauma. So they've just had to draw a line in the sand. So it is, when I put the government shoes on, I can see what they're trying to do because that growth is not sustainable. But then I put patient advocate shoes on and I say, well, you're dealing with a gram per kilo here for 10 grams, 15 grams compared to an 8 kilogram adult. There's a bit of a disparity there. So why is there? Look, they've had to draw a line in the sand. So they do. I don't get on the NBA's case too much because they have to do something because otherwise it's growing at.
Is donation part of that as well? So if we were to push just those donation as well of blood and plasma.
Yeah, yes, it would. Would it change the cost?
No.
Not that much. So we have, I think there are 3 suppliers of IVIG now.
Yeah.
CSL is one of them, but CSL makes money from IVIG. So CSL and ARCBS are like that. They're pretty closely linked. One's a big organisation, one's federally funded, but CSL buys the plasma from ARCBS and then makes IVIG, and other organisations bring it in from overseas. So yes, it would help, but I don't think you'd see an immediate drop. Because pharmaceutical companies love them to pieces. But they're also stakeholders in this. They would not. I don't think our medical care would be as good. They're big bad pharma, I get that, but it wouldn't be as good unless they weren't making money. It's innovation, unfortunately.
Yeah.
And if the federal government was going to throw all their money into it, great. But I see pharmaceutical companies as a stakeholder in it. I might be being a bit naive, but I think we're also a bit mature that, we can see through them at times.
Obviously, too, from a research point of view, obviously it's not very sexy and there's not a good famous person to have it, so we can advocate on things. But is there much research being done or research that's being done into other types of hematological diseases that reflect back on this?
So the focus really is on there's some new drugs out there. They're not filtering down to kids yet, because even the drugs that are being used in adults haven't got not 100% success rate. If that was the case, it would quickly come down to kids. But when you're dealing, one of the medications which is looking at interfering with the function of the spleen had a 20% improvement. No one's going to fund that to any huge extent because it's not worth it. Yet there are other haematological disorders, not to make you more frustrated. I look after a disorder called haemophilia. There's enormous research in haemophilia. Lots of the sessions over there around haemophilia. The only way that research, I'm going to be around for a little while, I hope, but the only way research will develop is starting at the basics of registry data. That's the first step. And then it'll follow on, because once you've got a coordinated cohort of patients, interested clinicians, etc., then research will come. It won't, in this space, I don't think it'll be driven by pharma because there's not probably the coordinated network of care for pharma to really latch onto just at the moment. So I think it's going to have to be driven probably from grassroots. You know, even questions how many patients in Australia, paediatric, are on those third or fourth line agents. You know, we don't know. And which agents work. You know, so we go through stepwise, but we could propose that to everyone and everyone could start to follow the same process. Then it becomes a little less frustrating because you know what the steps are, whereas at the moment it's all over the place. We just sort of make it up. It is, as I said, if we can centralise care, start to get some registry data, and importantly be able to provide some tangible support to families going through it, I actually think that's their achievable goals within a 2 to 5 year period.
And is there anything you on the paediatric side that you see coming that may filter down? Is there outside of the...
Look, whether or not, so the end plate, the weekly subcutaneous injections, so these are the TPO agonists, they haven't, so 5, 10 years ago we thought, thank goodness we've got something that's going to make a difference. We're involved in some studies. No, one patient made 0 difference. Another patient, there was a transient response. So unfortunately, and weekly injections for kids, you know, that's not particularly tolerable. So Revelade, which is the Eltroma bag, that may have an impact. The fact that the companies aren't really pushing for it to be registered and funded is sort of interesting. It means that it's, you know, probably, you know, not going to be great. No, I think, you know, if we can sort out a little bit more who's going to do well, who's not going to do as well in the setting of a splenectomy, that's probably where I would be interested in. Mabthera isn't without side effects. It can knock your immune system around a fair bit. So, but again, you know, we're sort of going through this low-level evidence, this guideline, not made up by us. You know, we sort of try and cobble it together. But if you could have a standard approach to chronic ITP or even acute ITP with bleeding across Australia, that would be really helpful. And the reassurance that I think it will touch wood, the reassurance that I think it provides families to say that we're just not making this up. You know what I mean? This is supported by everyone in Australia. We're all doing the same thing. I think that could be helpful.